Good afternoon, everybody. Today we are going to be talking about how the micronutrient test correlates with the cardiometabolic panel. A lot of you out there have performed cholesterol, triglyceride, and cardiovascular testing on your patients. And once again, once you receive those results, you've probably asked yourself, what's the treatment protocol that I should use for this particular result of my patients? Well, today I'm going to correlate on how specific nutrients actually will correlate with your triglyceride and cholesterol level. As you know, cardiovascular disease is still the leading cause of morbidity and mortality in the United States. And despite the fact that we have new medications, new surgical interventions, and of course we're always trying to enhance our patients into a healthier lifestyle, we still are addressing problems with nutritional deficiencies that are causing problems. And once again, this is something that we always have to keep in mind, that it's very important that we address the micronutrients as well as the macronutrients. You know, for a long period of time, we used to always limit the patient's fat intake or simple carbohydrates that would affect our cholesterol and triglycerides. Well, once again, today we're going to talk about specific micronutrient deficiencies that have a strong correlation with the cardiovascular markers as well as the diabetic markers. You know, diabetics have a high tendency for coronary artery disease, and you can see here that 50% of deaths in individuals with diabetes are due to coronary artery disease. And you see this all the time on advertisements when the pharmaceutical companies are instructing us that there's new medications to control the diabetics' blood glucose levels, because once again, we do know that this is a comorbidity associated with diabetes. So when you think about heart failure, you can see there's numerous nutrient deficiencies that play a role with cardiovascular disease. And I'm going to correlate a lot of these. Now, due to time limitation, I won't be able to cover everything, but for the most part, I will cover the vast amount of information here regarding these nutritional deficiencies. Specific markers that you look at, once again, are going to be controlled by these particular nutrients. And then we're going to talk a little bit about nutrient-nutrient interactions, because whenever we give a particular nutrient, we always have to question whether or not we're throwing some imbalance off with other nutrients. Now, one of the things that, of course, we always talk about is the cholesterol level, the triglyceride levels, but of course, we're really talking about lipoprotein particles. And this is where the cardiometabolic panel from SpectraCell goes into not just the size of the particles, but also the number of these different size particles, and then we correlate that with cardiovascular health. We also see this change with diabetics as well. So keep this in mind visually when you are looking at this and we're talking about different aspects of the cardiometabolic panel, that we're really looking at these particles in number as well as size, and how do we manipulate these particular particles. The phospholipid portion of this particular particle does not have any detriment to us. It's actually very beneficial that we have a healthy phospholipid membrane. And once again, I'll mention that a little bit as we get into specific nutritional deficiencies. So if you're new to SpectraCell and you haven't used their cardiometabolic panel, you can see that the next two slides are going to inform you of what's actually on the cardiometabolic panel. And once again, they're very connected in regards to nutritional deficiencies. You will see that one particular nutrient may affect the CRP level. At the same time, it may affect the glucose level, and that once again may also affect cholesterol and triglyceride levels. But when we look at these particular factors on the cardiometabolic panel, we have to ask ourselves, are we really getting to the root of the problem? Because a lot of times, for example, on this particular example, you see that the CRP is elevated. And maybe most of you out there would say, I'm going to lower that with turmeric, or I'm going to lower that with omega-3s, or I'm going to lower it with some other nutrient, and yet you're kind of guessing on what you're doing to lower that, because the question should be, what's causing that elevation. Yes, you can use some products out there that are anti-inflammatories, but are we really deficient in turmeric? I'm not discrediting turmeric to any degree, but the point is there a specific nutrient deficiency that is actually causing that CRP elevation? And then, of course, you can see below that there's an elevated homocysteine, and, of course, when we look at homocysteine elevations, everybody thinks about the big three, B6, B12, and folate. And we're going to talk about those as well as some other nutrient deficiencies that can actually elevate our homocysteine. Now, continuing with that, you're going to see that part of this panel also looks at the omega-3s. And then, of course, we look at inflammatory markers like arachidonic acid. We, of course, look at essential fatty acid, linoleic acid, and what's the ratio of these omega-6s to the omega-3s. And once again, we'll correlate this a little further down into the webinar today when we are looking at nutritional deficiencies. So let's start talking about adiponectin, because adiponectin, once again, is becoming a hot topic today in endocrinology. We're looking at this for several reasons, especially with the connection with diabetes. And, of course, here's a little background about adiponectin. Well, once again, why are we so interested in adiponectin? Because adiponectin effects, you can see, are listed below. And if we can control or enhance this particular hormone, then, of course, we can, once again, also affect these results or, once again, the overall effects of adiponectin on the body. It's very important to realize that even though I'm going to go into some of the nutrients that are associated with adiponectin, that we can't just always address one of those nutrients. We have to look at them as a group because, as we know, there's definitely a nutrient-nutrient interaction. I'm going to get that across over the rest of this webinar. So the first one we're going to talk about is vitamin E and adiponectin. And vitamin E is a very interesting nutrient because, as you know, vitamin E has been looked at for numerous years in cardiovascular health. Well, in this particular slide and information, you can see that adiponectin and vitamin E are connected because of the effect that adiponectin and vitamin E have that are similar to the TZDs. That vitamin E actually works kind of like a TZD with diabetics. The effect that it has on adiponectin, once again, is significant. Now, we always look at all of the vitamin E's, not just alpha, but we look at alpha, beta, gamma, and delta. And now, of course, we're also looking at tocotrienols as well. But the point is that there is a specific mechanism that is being looked at and how this vitamin E may be beneficial. Now, what's interesting about vitamin E is if individuals take a large amount of omega-3 fatty acids, some of those individuals may actually show a vitamin E deficiency. And the thought process is that possible elevated or lipid peroxidation of these polyunsaturated fatty acids and, as a result, causing this vitamin E demand to go up. So there's an important point to remember that if you have patients on high amounts of omega-3s or they're on high amounts of polyunsaturated fats, that you should be evaluating their vitamin E status because, once again, this is something that could have an impact on them from a glucose regulation effect. Niacin is another nutrient that has been shown to have adiponectin correlations. As you can see here, that there's a fourfold increase in adiponectin expression, once again, when niacin has been introduced. And this is very important. We know we've used niacin in various forms. We've used the nicotinic acid form, which is highly beneficial for the triglyceride levels, cholesterol levels, as far as lowering LDL, increasing HDLs, and, of course, we also have seen niacinamide being used in the benefit of the glucose, or I should say the insulin receptors and glucose regulation. Vitamin D, once again, has also been getting a lot of press in regards to the correlation with diabetes. Of course, you can see here some benefits of vitamin D. One, It helps insulin synthesis and secretion. It's also been shown to affect the insulin receptors. So, as you know, there's a large portion of the population that's vitamin D deficient. A lot of people right now are looking at vitamin D levels and seeing the correlation of numerous pathologies, but this pathology, once again, has received a lot of press in this particular vitamin. Now, whenever we talk about vitamin D, we always need to talk about magnesium because, of course, magnesium absorption is enhanced with vitamin D, and the hydroxylation of vitamin D is affected by magnesium. So they have a very strong synergistic relationship to one another. But if you just look at magnesium alone and you see that it has these numerous benefits to the glucose control through insulin sensitivity, it's very, very important that we always consider this magnesium. As you know, serum magnesium is not a very sensitive marker to look at when we are evaluating magnesium. There are numerous things that we'll talk about today that affect our magnesium status, and once again, will eventually affect our glucose status and some of the products on the lipid profile. So we have to keep in mind that some of the medications out there that are used in cardiovascular medicine may actually be affecting this mineral and causing some adverse effects that, once again, we'll have to try to address by other means. Another nutrient that has been shown to be very beneficial with the diabetic and as affected by our glucose status is zinc. And once again, as you know, magnesium has over 300 functions in the body. Zinc has been said to also have over 300 enzymatic or related functions. And so this is a very important nutrient to look at. Now, who might be deficient in this particular nutrient or be more prone to this deficiency? You know, we always talk about vegans as being more prone to B12 deficiency when they are strict vegetarians like that. Well, zinc is also a nutrient that is commonly deficient in vegans. Now, some of you may say, well, you can get zinc from nuts and seeds, so why should they be deficient if, once again, they're vegan? Well, the bioavailability of zinc from meat versus your nuts and seeds is significantly higher from animal protein than it is from plant protein. So it's not so much the content of a mineral in the food, but also the bioavailability of that particular nutrient. So I think it's very important to keep that in mind, and we shouldn't just anticipate that if someone consumes a food high in a particular nutrient that they're going to satisfy their daily need, because we know that that's not the case in a lot of our individuals. C-peptide is another marker that SpectraCell looks at, and as you know, this is a important product to measure because, once again, it helps distinguish between type 1 and type 2 diabetes. It is very important to look at from the standpoint if a person is taking insulin for their diabetes. But once again, this precursor to insulin, and once again, insulin effect on the insulin receptor and regulation of glucose is highly dependent upon nutritional status. So one, yes, we want to make sure that the patient is able to produce insulin, but even if they are producing insulin, are the receptors sensitive enough, or are they working optimally to really control our blood glucose? Because we know if we don't control our blood glucose, then of course triglyceride levels and cholesterol levels may also elevate. So it all comes around to several nutrients when we're looking at diabetes as well as heart disease. One product that's primarily talked about with cardiovascular disease is, of course, the CoQ10. But this particular nutrient is also very important, as you can see, for the diabetic. And so when we're talking about inflammation today, one of the nutrients that you definitely want to look at is CoQ10. As I mentioned on the earlier slides, and I showed you that elevation of CRP, the question I'm asking you is, when you were looking at that slide, did CoQ10 ever come into mind with you is one of the treatment factors for lowering your CRP. As I mentioned, a lot of people will use herbal products, a lot of people will use fish oils to lower CRP levels. But if a patient has a deficiency in CoQ10, they actually could have an elevated CRP. And so that would be getting to the root of the problem versus putting this person on omega-3s that may have adequate omega-3 status, but yet they have a deficiency in CoQ10, and once again, that could be causing their elevated CRP. So you're getting to the root of the problem. We also know that CoQ10 is related with other aspects of diabetes, such as neuropathy, and of course, you all are aware that CoQ10 deficiency can occur very easily in individuals that are taking statin medications. Here are some of the issues that have been associated or affected by CoQ10. So when people have deficiencies of CoQ10 from the myocardial standpoint, you can see that once again, the literature has correlated some of these relationships. And I think it's very important to keep this in mind whenever we talk about cardiovascular health. So here a person is having a situation where they have elevated cholesterol levels, they're on a statin, and if they're not on CoQ10, once again, they may cause some other problems down the road. Here are some other benefits of CoQ10 from a cardiovascular standpoint. So once again, if any of your patients have these situations, in fact, the other day I had a patient come in that he has a history of angina for the last 6 to 9 months, has gone through all the testing by cardiologists that, once again, are typical of cardiovascular medicine, and he was told by the cardiologist that everything was normal. He had no idea why this patient was experiencing angina, and of course, I sent the person out for some testing, of course, on the micronutrient testing along with the cardiometabolic panel. Now, I've not received the results yet, but it won't surprise me if, once again, this patient is deficient in CoQ10. So it's very important, once again, when all the standard cardiovascular tests come back normal and people still have angina or they have shortness of breath or various other particular signs and symptoms, that we look deeper into the person's biochemistry and see if something in their biochemical makeup is actually deficient that has been shown to be related to these signs and symptoms. You can see here CoQ10 has been shown to be beneficial with congestive heart failure. Now, one of the things that you will see here in the next few slides is it's not just recognizing the CoQ10 deficiency with congestive heart failure or considering this, but also the dosage. And that's where it's very important that we realize that when we are treating patients with nutritional supplementation, or, of course, if you're a doctor that prescribes medication, that we get the right dosage of medication to the patient. Because we can't just assume that 100 milligrams of CoQ10 is going to be beneficial for every patient of ours. And once again, you can see here that dosages have ranged from anywhere from 60 milligrams to 300 milligrams per day. And there's some cases out there that are even higher than 300 milligrams. Now, this is where I would like to talk about the fact that we just can't put somebody on a supplement like CoQ10 and expect that medicating of that patient that we don't have to monitor them. Because something that has been shown to occur with CoQ10 supplementation is a carnitine deficiency and or a panthenate deficiency can occur. Now, carnitine is essential for cardiovascular health and other aspects of health, and panthenate has an impact on several systems in the body as well. So once again, when we put someone on a particular therapeutic dosage of a nutrient like CoQ10, we have to realize that we have to monitor these individuals on a regular basis to assure that we're not causing some other nutritional deficiency that may result in a condition we're trying to help, in this aspect, cardiovascular health. So you can see here that CoQ10 has been shown to be low in specific candidates out there with cardiovascular dysfunction. Laboratory diagnostics, once again, have shown to reveal low CoQ10 levels, and once again, low CoQ10 levels have been shown to affect ejection fraction. So this is a very important point. So once again, one of the diagnostic features from cardiologists is they check ejection fraction of their patients. And if it's lowered, the question is, what do they do for those particular individuals? Are they really going and looking into the biochemistry of these individuals and saying, oh, you could benefit from CoQ10? Or are they putting them on some medication that's trying to help them? Or maybe they're going to the point that if the patient's ejection fraction keeps declining, that are they considering for a heart transplant down the road? So the point is that these have to be looked at from a biochemical standpoint, and depending on their medications that may be on, may determine whether or not they're more prone to CoQ10 deficiency. So think of this, that here's a patient that has an elevated cholesterol, they were put on a statin medication, and down the road they start to decrease in ejection fraction. Are we correlating that long-term usage of statins that could have caused a CoQ10 deficiency that eventually is causing them to have a congestive heart failure type of presentation? So let's go back to magnesium, because as I mentioned, magnesium deficiency is associated with numerous systems. And today, of course, we're talking about the cardiometabolic panel, which is primarily looking at diabetes and cardiovascular health. Well, as you can see here, stress, this could be physical stress, this could be psychological stress. Of course, oxidative stress that a lot of us hear about today is affected by magnesium. Inadequate diets. Today, a lot of people are trying different diets, whether it's vegan diet or another type of diet like gluten-free, or they have allergies, and so they're limiting certain food intakes because of those allergens. That may be pushing them to magnesium deficiency. Of course, maybe they have some history of GI problems. It could be a simple thing as irritable bowel syndrome, or more serious like Crohn's disease or ulcerative colitis. And then, of course, we talk about diuretics. Now, when we talk about diuretics, we're not just talking about prescription diuretics, that we're also talking about diuretics that are in foods. For example, caffeine and alcohol, as you all know, work as diuretics, and these can cause magnesium deficiency. So if a person has a tendency to drink a couple cups of coffee a day or a couple glasses of wine at night, and this is a regular part of their lifestyle, then once again, this could be causing some magnesium deficiency. And they may be doing that consumption of coffee or caffeine products because their energy level is low, and by consuming all that coffee or caffeine, they're eventually causing magnesium deficiency. And as you know, magnesium is essential for ATP production, and of course, will provide us with energy if it's adequate. If it's inadequate, of course, we're going to have a lack of ATP and have fatigue. So they're not really solving the problem. They're just putting a temporary fix on their fatigue, but eventually they're causing major problems. And then those individuals come to you or me, and they say, oh, I have an elevated cholesterol level, I have an elevated triglyceride level, I've never had that before, and I can't understand why all of a sudden. And if a clinician has not looked into it in an in-depth manner, they may say, oh, well, your family has a history of cholesterol or triglyceride elevation, so it's probably hereditary. Is it really hereditary, or is it really a nutritional deficiency that has developed over the years that now is displaying itself as another factor like the elevated lipids, as I just mentioned? So here's some evidence, and you can see, of magnesium's relationship with hyperlipidemia, and of course that correlation going into diabetes, and of course associated with high blood pressure. One thing a lot of people don't know is that magnesium actually works as an antiplatelet aggregator. So it's beneficial in that aspect, but it also has, of course, a muscular relationship and, of course, an overall regulation of the cholesterol and triglycerides. And magnesium is easily depleted in our everyday life because of stress in everybody's life, as well as some of the other things I mentioned with the caffeine consumption and alcohol consumption as well. So here are some of the things that really affect our magnesium status, okay, or have an impact on us. It works as a calcium channel blocker. It modulates lipid metabolism. As I mentioned, stress, physical, psychological stress. Let me give you an example. I see quite a few athletes in my practice, and it is not unusual to see these athletes with magnesium deficiencies. And their heavy exercise regimens have a tendency to either demand more magnesium or, once again, cause them not to consume certain foods that are high in magnesium, and they can't keep up with the demand. And as a result, they will try various things, like I said, caffeine to enhance their exercise levels, and of course this causes magnesium problems. Or once again, they eventually develop high blood pressure, high cholesterol, high triglycerides, and they go to a clinician. They say, well, I don't understand this. I'm exercising all the time. How's my cholesterol high? Why is my triglycerides high? And once again, it could be because of this nutrient deficiency. The first thing that most people do is they put them on a medication to lower their cholesterol or their triglycerides, or they may say, what are you doing from your fat intake or your carbohydrate intake? But they don't look deeper into the micronutrients. They're only looking primarily at the macronutrients. You can see here, here's some evidence showing you that adrenaline definitely has an effect on our magnesium status, and this is why magnesium and stress are so strongly correlated with one another. And then you can see here that when magnesium did get deprived in animals, that there definitely was a cardiovascular result of this. So once again, this is something that we have to look at on a daily basis, and we have to measure from an objective standpoint rather than just saying, well, everybody that's under stress should take magnesium. Well, once again, I'm going to show you why you can't just do that, because there's some other things that can occur when we give high dosages of magnesium. Going back to the CRP, as I mentioned, we talked about CoQ10 having an effect on our CRP. Well, you can see here that magnesium has an effect on CRP. So here's an individual that comes to you, you're doing a cardiovascular workup, and you've noticed over the last year, 2 years, that the person's CRP keeps elevating. Now, it might be in a borderline level, it might be in a severe elevated level. But whatever the case, there's a reason why it's happening. So if you recommend omega-3s, you may lower the CRP, but are you correcting the problem, or are you just masking the problem? We've seen that with other vitamins. For example, I'm going to go out of cardiovascular health for a second. There's evidence out there that people can be anemic from, say, B12 deficiency. But if you give enough folic acid, you can actually correct the CBC findings and correct the anemia. At that point, you would think, oh, I've done the right thing, but in actuality, when they've looked further into some of these cases, that the person had a B12 deficiency that was covered up by high dosages of folic acid. So you're actually masking that problem. The same thing is true with this, with the CRP, is you could be given fish oils to lower CRPs, but you're really not getting to the root of the problem because magnesium or CoQ10 or some other nutrient may be deficient. So that's once again why we want to look at that. If I ask the question to you before we even started this webinar today, what nutrients do you think could have an impact on triglycerides? I think I'd be very surprised if a lot of you or all of you said vitamin D. A lot of people do not correlate vitamin D with triglycerides, but once again, this is something that we have to consider. Now, there's not a lot of information out there right now regarding vitamin D and triglyceride levels, but the point is it definitely can have an impact on us. And going back to, as I mentioned earlier, vitamin D has a very strong connection with diabetes and this is something we need to look at. Of course, I talked about this earlier with niacin and the relationship with adiponectin. Here you can see there's a strong relationship with triglycerides. In this particular one, when we talk about niacin, we're looking at the nicotinic acid form. And that's the one, of course, that makes the patient flush. Now, time release could be the same, but there's one form out there called inositol hexaniacinate, which is also known as the non-flush form, and that one has some very poor evidence on benefiting the triglycerides or cholesterol levels. And I do not recommend that one to my patients, or I really don't highly recommend that you use that product, because once again, the evidence isn't very strong on that particular form of niacin. You can see here that one of the main markers that SpectraCell looks at with the cardiometabolic, and it's significant in the literature, is a lipoprotein A. And this is a highly hereditary marker. This is one that diet and exercise really have little benefit to this. Even statins don't have a significant impact on this. Niacin has been shown to have the strongest impact as far as lowering lipoprotein A levels. And I'm going to show you some, the standard lipid profile versus what SpectraCell tests for on the cardiometabolic, and I think you'll see the reason why they look at all these particular markers. And once again, you can see that there's quite a few reasons why niacin could be beneficial if an individual did have an elevated Lp(a) marker. So these are some of the general mechanisms that have been noted in the scientific literature. And then, of course, even though there's some benefit for niacin, there are some adverse reactions. Now, I've used niacin for numerous years, and I've never had the major ones that are listed here with hepatotoxicity or the significant elevation of uric acid levels. Yes, there's been some evidence of glucose elevations. I've seen patients, of course, the flushing is something, and the pruritus is very common with those individuals. And some people do have GI complaints with this particular nutrient, especially if they've taken it on an empty stomach. But once again, this is another reason why we have to do some monitoring of these individuals. We just can't give them these nutrients and expect them not to have any side effects with that. L-carnitine is another nutrient that has been shown to affect lipoprotein A. So this is something else that you should look at. And as you can see in the second bullet of this particular slide, I do mention that you should monitor CoQ10 and pantothenate whenever you give L-carnitine or vice versa. So this is why it's very important that we do regular testing and we do a micronutrient test along with the cardiovascular panel. If you just do the cardiometabolic panel and you ever take the opportunity to talk to one of the consultants at SpectraCell, you will probably hear from them, well, you need to do the micronutrient test with them. If you talk to me, you will definitely hear that from me, because you can see here that there is a strong connection with some of these cardiovascular markers along with diabetic markers and the micronutrients. And we can't just assume what nutrient to give that individual if some of those markers are elevated. Here is some more information, general information about L-carnitine, where it's produced in the body, where it's stored in the body. So you can see that it definitely has a significant impact on skeletal muscle and cardiac muscle. And this is why if we do give CoQ10 and cause a carnitine deficiency, it can have a detrimental effect on our cardiovascular system. Now, as I mentioned with CoQ10, as we look at particular dosages for benefit, the same thing with carnitine. And if you look into the literature to really see some benefit of lowering lipoprotein A, most of the literature will talk about 2,000 to 3,000 milligrams per day of carnitine. Now, once again, when you start to give that amount, you have a good chance or some chance of actually causing a CoQ10 or pantothenate change. So you have to, once again, always keep that in mind with the patient. And that's one of the things I emphasize to my patients when they take this testing is from day one I tell them, we need to do follow-up testing with you because there's some imbalances that may occur with my dosing of certain nutrients, and we want to make sure that we're not causing some other problems while we're trying to correct some initial problems. Vitamin C is another nutrient that has been associated with cardiovascular health. Once again, in a couple aspects. On this particular aspect, you can see here, it has some beneficial effects as far as protecting vitamin E. Of course, we know lipid peroxidation is part of the whole atherosclerosis and arteriosclerosis mechanism. So anytime we can limit lipid peroxidation, that's a good thing. Vitamin C also has been shown to help with high blood pressure. There's some evidence that vitamin C deficiency does cause hypertension. So once again, vitamin C has a couple different aspects of benefit for the cardiovascular patient. As I mentioned, vitamin E has an impact on adiponectin and kind of a relationship or very similar aspects as a TZD in diabetes. Well, once again, there's some benefits of vitamin E also with cardiovascular health. So if we're using vitamin E to help the diabetic, we're also going to help their cardiovascular health as well. And as I mentioned earlier, if some individuals are consuming large amounts of omega-3s, sometimes it has shown to cause a vitamin E deficiency. So that's another nutrient-nutrient interaction that we want to keep in mind. There's some more benefits of vitamin E or mechanisms on how vitamin E may help, once again, in regards to cardiovascular health. And this is one of the reasons, if you look, of course, in the relationship with the platelets, that it does have a inhibition of platelet adhesion. And once again, this is one reason why individuals have to discontinue this particular nutrient if they're going in for a surgical procedure. Now, there are certain levels that we can get to before that really has to occur according to the literature. But the point is, for safety reasons, it's always good to lower or discontinue this particular nutrient prior to any surgical procedure. And as long as there is no significant adverse reason why a person couldn't resume this after surgery, once again, they should resume this because vitamin E is very beneficial for healing as well. So vitamin E can be used for enhancing healing in individuals as long as there's not a contraindication for vitamin E post-surgery. Selenium and vitamin E are very synergistic with one another. Once again, you can see that selenium is a component of glutathione peroxidase, so it does have a correlation with glutathione, as you know, sometimes known as the master antioxidant. Selenium has been shown to modulate LDL and HDL. If you've ever had a patient that exercises a lot and they can't increase their HDL levels, no matter what they've done in the past, this is one nutrient. It's not the only nutrient, but this is one nutrient that should be considered because, once again, selenium has been shown to increase HDL levels and lower LDL levels. It also, as you know, is highly connected to thyroid function, and of course, people that have hypothyroidism do have a tendency to have elevated cholesterol and or triglycerides. So once again, that's another nutrient correlation between a couple systems. Chromium, even though most of the time people talk about chromium and glucose regulation, chromium has been shown to also affect cholesterol levels. So once again, if a patient does have an elevated cholesterol level, that this is one of the nutrients you should consider. If they have an elevated glucose and cholesterol level, it's even a stronger indication that chromium may be involved as far as a deficiency status. When we think about cardiovascular health, one of the things that I think is very interesting is a lot of people don't think about the integrity of the vessel itself. The collagen, the elastin, in these particular structures. And copper and zinc play a very strong role in both of those proteins. We can't make elastin, and we cannot make collagen without copper or zinc. There's some animal studies out there as well as human studies showing copper deficiency associated with aneurysms. So once again, this is something that we should always look at, and because of, once again, the correlation of the collagen and elastin. They also work as antioxidants, and we're always talking about oxidative stress and inflammation. Once again, these two, because of their relationships with superoxide dismutase, should be considered when we are thinking about inflammation. We always look at those two as a certain ratio. We usually want to keep zinc to copper in about a 10 to 1 ratio. If we take large amounts of zinc without copper or vice versa, we can cause that imbalance. Another marker that's looked at on the cardiometabolic panel is homocysteine, and of course, see that this, once again, is an example of the methylation pathway and homocysteine regulation. And if you look at, of course, one aspect here, the PLP, that's your B6. Then you look at THF, of course, that's your folate relationship. Your FAD, of course, is your riboflavin relationship. And, of course, then we have B12. And, of course, other aspects here with methionine and SAM and so on. The point is that there are several nutrients that play a role with homocysteine regulation. And as I mentioned earlier, a lot of people just look at the big three, the B6, the B12, and the folate. But you have to consider serine, you have to consider choline, you have to consider riboflavin, glutathione, and cysteine. So all of those have an important role with this particular product in the blood. And once again, this is something that's surfacing more and more. It's not just in cardiovascular health anymore. We see it in skeletal health with relationship of osteoporosis. We see it, of course, in neurology with dementia and Alzheimer's. So homocysteine is a very important marker to look at. But once again, since we're talking about cardiovascular health today, this is, of course, one of the markers on the cardiometabolic panel that is, once again, important. And this is why you want to order the micronutrient test with it, because of finding out what particular nutrient may be causing that elevation of the homocysteine. So by looking at this, once again, I'm going to take you through what a standard panel is, and you're all familiar with this, but the big difference between the standard lipid panel and what SpectraCell offers is the cardiometabolic panel. Looking at this, you can see there's only 5 markers per se that are being looked at. We're looking at the total cholesterol, of course, the triglycerides, the HDL, the LDL, and so-called non-HDL cholesterol. Now, some of the panels out there will give you the HDL to LDL ratio, but as you know from the standard panel, you do not get, of course, the particle sizes of the particular lipoproteins. You don't get the breakdown of the LDL, in this case, the LDL3, the LDL4. You don't. The intermediate, or also known as remnant lipoprotein, is also noted on the cardiometabolic. And then, of course, you get the breakdown of the HDLs. For those of you that aren't familiar with that, the HDL is broken down into 3 subsets, HDL 2A, 2B, and 3. It's the 2B that is really the more beneficial type of HDL. And once again, you can see from the previous slide of the standard panel that you didn't receive that. In addition, you get the CRP, you get the lipoprotein A and apolipoprotein A1 and B, and also the homocysteine. So you can see that there's numerous markers that are noted on this. And then, of course, in the diabetic standpoint, you get the C-peptide, you get the HbA1c, you get the insulin levels, and some other markers as well. Now, this is something that you would receive on a cardiometabolic panel that, based on all those markers that I just showed you on the previous slides, those particular results are noted on this graph. And I find this graph to be very important and substantial to the patient because most patients, I'm definitely like this, they are visual. They like to see things visually and to see how this correlates. And this actually shows a very good result because the patient is represented by the black line. And as a result, that black line, we want it to be in the green. Now, the left lower corner, the small peak, that's more or less representing the triglycerides. And as you know, triglycerides are very numerous on the VLDL lipoprotein, and so you can see that. Then you can see right next to that on the bottom of the slide, you see the RLP, or also known as the intermediate dense lipoprotein, but in this case remnant lipoprotein. Then moving to the right of that on the bottom of that graph, you see LDL1 and 2, and then to the right of that dotted line, you see LDL3 and LDL4, and then at the very far right, you will see that's where your HDLs are broken down into the 2B, the 2A, and the 3. One important point that I always emphasize to new clinicians using this report is if you look to the right of that dotted line, you'll see how the pink or the red goes much further down on the right side of that dotted line to the left side of that dotted line. And the reason why that is because we want to catch the LDL3 and the LDL4 earlier than the LDL1 and the LDL2, because the LDL3 and the LDL4 are more atherogenic than the LDL1 and 2, and that's why it's lowered here compared to over here. So if you move this peak, in the middle peak, over to the right of the dotted line, you would see that part of it would be in the yellow, and maybe a very top of that tip would be in the pink. But the point is that these are much more damaging than the ones to the left from an atherogenic part of it. Of course, SpectraCell will also rate that patient's status if they have a low cardiometabolic risk factor, and once again, that's based on numerous findings on those markers that I just mentioned. So once again, a patient hopefully will go from if they're in a bad state to a good state. So if they're in a bad state, it would be a high risk, and of course, hopefully you get them to the point where they're in a low risk. These are the diabetic markers that you will see on, once again, the cardiometabolic, starting with the insulin level, and of course the fasting glucose, your typical HbA1c, then you get the C-peptide along with the adiponectin, and then, of course, you determine based on metabolic syndrome traits how many traits that particular patient has. And right below that, you do get the standard lipid panel, but once again, you get a lot more information than just that when you get the cardiometabolic panel. Of course, your patient is also rated according to those diabetic markers, whether they're at high risk, low risk, or moderate risk. So that's something very important. And once again, a lot of clinicians use this particular panel for prevention along with monitoring of the president's particular status. In addition to those diabetic markers and those lipid markers for the cardiometabolic panel, also you will see that there's an omega check. And this is where the omega-3s, omega-6s are actually being evaluated in the patient. And if you look in the middle column where it says out of range, you see the omega check, the person gets a number. It's 4.8. We want it greater or equal to 5.5. And how you get that number is by adding up those three omega-3s, the EPA, the DPA, and the DHA. And when you add all those up, of course, that would, in this particular example, that equals 4.8. So patients of yours may be taking omega-3s from various sources. It could be flaxseed oil, it could be fish oil, it could be from algae sources or whatever. And they're just assuming that their levels are good, that they're taking 1,000 or 2,000 milligrams a day, and they think that that's going to protect them from heart disease or some other type of disease. And then when you measure it here, it shows that it is not a good level. So what they were assuming was good is actually not at the level they should be. And once again, you can tell them that, look, your CRP is elevated, and one of the reasons why your CRP is elevated is because your omega-3s are not adequate based on this testing, despite the fact that you are taking some omega-3s. This is a further breakdown. It shows you a breakdown of omega-6s, like arachidonic acid and linoleic acid, and then the omega-6 to omega-3 ratio, and then once again, as I mentioned earlier, the overall omega-3s. So now what I want to do is I want to show you and take you through a few cases here or situations where there's some correlations with these particular individuals and how you could correlate this to, once again, the cardiometabolic panel. As I mentioned, here's a female patient with the micronutrient test. And as I mentioned earlier, that homocysteine is a concern of cardiovascular health. And in this case, this person has a B12 that's borderline level. They have a B2 that's borderline. And of course, they have a vitamin D that's borderline and magnesium and copper borderline. Now, all of those are related to the things that we talked about earlier, diabetic status and or cardiovascular health. So if you just ordered this particular panel on this patient and did not order a cardiometabolic panel, you may be missing out on two major conditions that are coming down the road. One, diabetes, and two, cardiovascular disease. So by doing a micronutrient test initially, this should give you some indication that you should do additional testing because, once again, this person is, once again, related or could be related to those two conditions. So it's very important that we keep that in mind. Going a little further here, you can see in some additional nutrients, you can see chromium is borderline. She has a deficiency of glutathione. Her CoQ10 is borderline. Selenium is borderline. Vitamin D is abnormal, it's functionally deficient, and then vitamin C. So you can see that several of these particular nutrient deficiencies are not just there to say, oh, yeah, you're deficient in these, we need to correct these, but what other testing procedures should I order to really rule out or maintain your health or help your health, especially if this person comes in and they say, you know, I just want to have a wellness check. And you start out with a micronutrient test, you see all of these borderline and some of these functional deficiencies, it should stimulate you to think, oh, I should go and do some further testing, such as the cardiometabolic, because you have some nutritional deficiencies that can affect or push you towards diabetes or, once again, cardiovascular disease. So an initial micronutrient test, once again, is very beneficial on leading you or to predicting that there may be some other issues down the road. So I talked earlier about micronutrient testing and nutrient-nutrient interactions, and one of the main nutrients I talked about was the one about magnesium. And I mentioned about magnesium and how beneficial it is from a diabetic standpoint and from a cardiovascular standpoint. So if you're out there just saying, well, if it's going to help both and I have a diabetic that also has cardiovascular disease, I'm just going to put them on a high dose of magnesium. Well, you can see here that that actually was done, that this particular individual started taking high dosages of magnesium because they had a history of atrial fibrillation. What resulted was a B1 deficiency. So B1 deficiency can actually occur with high amounts of magnesium and vice versa. High amounts of B1 have been shown to affect magnesium. Well, B1 deficiency has been shown to cause cardiovascular damage. And, of course, when people have beriberi, the B1 deficiency, we know that it primarily affects neurology and cardiovascular systems. So, once again, you can see that this particular micronutrient test actually picked that up, that this person's magnesium status was very, very good post-magnesium supplementation, but secondary caused a B1 deficiency. So, once again, we have to emphasize this to our patients, and as clinicians, we have to be aware that we always need follow-up testing, make sure that we are not causing some other nutrient deficiency that can cause a bad result in the same system we're trying to protect. In this case, cardiovascular health with the atrial fibrillation, high dosage of magnesium, and causing a B1 deficiency, which has also been associated with cardiovascular disease. You can see in this case, this person has a fructose sensitivity abnormality, and that fructose sensitivity could be caused by too much fructose consumption, refined carbohydrates such as, of course, sweets. It could also be due to, say, soft drinks, but it could also be related to some deficiencies. We know that B3, as far as niacin, has been related to this. We also know copper has been related to this as well. And we know that fructose sensitivity can eventually cause insulin resistance. So it's very, very important that we correlate then, if we find this with an individual, that we address it. Here you can see that this is an interesting case. You know, we talk about cardiovascular health, and we also talk about diabetics, and we say one of the best things for cardiovascular health and to prevent diabetes is exercise. Well, here's a 75-year-old female that exercises on a regular basis, and you can see she has some deficiencies. She has chromium deficiency, she has zinc deficiency, she has an oleic acid functional deficiency, and she has what we call a glucose-insulin interaction. So her insulin receptors on the lymphocytes are abnormal. Well, chromium affects that, zinc affects that, B3 affects that. And then she has some borderline deficiencies, as you can see noted here. The point I'm giving and trying to emphasize on this is that here's a person that exercises on a regular basis to help prevent those two major diseases, cardiovascular disease and diabetes, and yet she has some deficiencies that have been strongly correlated with diabetes and cardiovascular disease. And if they're not taken care of, that exercise regimen that she's doing is not fully protecting her. So she has to address these deficiencies as well. And so those summarized on the front page there, you can see, are noted on these graphs as well. And if you look at the bottom of this particular slide, you will see that zinc is very, very poor status. So this is a nutrient, as I mentioned, that affects insulin receptors. It affects the integrity of the vasculature, of course, being responsible for elastin and collagen formation. And one thing that I haven't really mentioned but is very important about this slide is the oleic acid status. The oleic acid has a strong correlation with mineral uptake and fat-soluble nutrient uptake. And so that zinc deficiency may be partly due to the oleic acid status in this individual. One thing also that's interesting is when you start supplementing zinc in higher dosages can cause a folate deficiency. And you can, if you look at the top of this slide, you can see that folate is almost deficient. And if you continued or if you incorporated zinc supplementation, you definitely would have to monitor that, because if folate starts to drop, then that may increase our homocysteine levels, which of course can be damaging from a cardiovascular standpoint. So here we're going to give zinc to maybe prevent a diabetic type of situation or help the vasculature integrity, and then we're going to cause a secondary problem like folate deficiency, which can affect homocysteine and also cause some insult there. So I think you get the point that it's very important that we monitor these particular individuals. And here you can see that the glucose-insulin interaction is abnormal, the chromium is abnormal, and of course something that has to be addressed, as I mentioned. Well, let's take that situation and put it into the aspect of this particular cardiometabolic panel. So you can see here we want these numbers or the person's results to be in the green. So they're noted by these little diamonds in each of the colored graphs, and of course where it says patient results, if they're in a good status, their numbers are highlighted or circled around with green. If they're in a bad status, they're circled in red or pink. And so once again, based on that, this person's at a moderate risk. If you look at this particular individual, they do have a significant elevation of cholesterol. Their triglycerides and HDL are good. So here's an aspect of the exercise helping this individual with the 103 HDL, and say, yeah, but the person's cholesterol is high, but maybe that's high because they have a good HDL, or I should say a high HDL here. And she does have a good HDL2B, but once again, she also has a poor status of the of the LDL4. So even though the HDL is good, she has a bad marker of the LDL4. If we go further down and we look at some of these others, this apolipoprotein B is a hereditary marker, and that's something we have to address. And her lipoprotein A is also a hereditary marker. So the exercise is not affecting this to any significant degree. And so here this woman's exercising, trying to maintain or help her cardiovascular health, and yet she has a marker that's not being affected. She's 2 times normal. If you round this off to 30, you can see that she's 65.8, so over 2 times normal. If you take those numbers and you put it into these graphs, you can see here that she has some very good markers. The triglycerides are here. Her HDLs are very good. But she does have a risk here with the LDL1s and LDL2s. She does have some elevations in LDL3s, as we noted, but once again, you can see that she's still at risk because she does have some markers that are not picked up on the standard lipid panel. Going further into her diabetic portion, you can see here that she has a borderline HbA1c of 5.6. We know she has a zinc abnormality. She has a chromium abnormality. So once again, that is putting an impact on the HbA1c. She's averaging about a 114 glucose level, and so once again, that has to be addressed as well. If you look at her omega check or her omega-3s in her system, once again, you can see that 2 of these are abnormal. We have the EPA that's low, the DPA that's low, and the DHA is good. So once again, despite the fact that this woman is exercising, they may have consumption of omega-3s in their dietary habits or supplemental habits, it still is not adequate based on this objective testing. So to summarize this, you can see these are what we would see on the summary page of this particular individual, that there's definitely some concerns with her cardiovascular health despite the fact that this individual is exercising on a regular basis. And then once again, if you look at the summary of the omega-3s along with the other markers of the cardiovascular panel, the DENS4 and the buoyant HDL2B and non-HDL particles, you can see there's some concerns there. If you think about just her lifestyle and what she's doing, she's exercising, she's in good weight status, you would think that she's in good health, low cardiovascular risk. But when you look at the individual from objective laboratory diagnostics, she's at a moderate risk. So once again, and now we have some correlations because we know chromium levels are abnormal, vitamin D levels are abnormal. Once again, her zinc is at poor status, and so they all correlate. So the point of this webinar today, hopefully you received the information from a standpoint of how do I incorporate this into my practice, and if you have been using a micronutrient test or you have been using a cardiometabolic panel, that you see that you have to really use both of them together, because you're going to find the root of the problem from a micronutrient standpoint if you correlate or use the micronutrient test in conjunction with the cardiometabolic panel. And this is something that is strongly noted in the literature. I've given you some examples of this. I've shown you the scientific literature and how those particular micronutrients play a role with cardiovascular health as well as diabetes. And I think it's significant that we always consider that. And lastly, not to just look at the micronutrient from a treatment standpoint, but we also have to look at the micronutrient testing from a nutrient-nutrient interaction. And we also mentioned some of the medications that are used out there, like the statins, and how they affect our micronutrient status. So I hope you find that this webinar was beneficial to you and correlated some things from diabetes to cardiovascular and micronutrient status, and once again, will be helpful to your patients in the future.